A very warm welcome to everyone who's joining across the world to our Health for the World International Grand Rounds. We welcome you here. I'm honored to introduce our speaker today, Dr. Judith Gadde, who is a renowned pediatric neuroradiologist and Director of Academic Innovation at Lurie Children's Hospital of Chicago and Assistant Professor at Northwestern University. She's a phenomenal educator and leader in the field of neuroradiology. She has a website dedicated to the neuroradiology cases, and she posts them on social media. And she's just absolutely phenomenal. So I can't wait to hear the webinar. And please feel free to ask any questions in the Q&A box, and we can address them towards the last 15 minutes of the webinar. With that, I turn it over to Dr. Gadde.
Thank you so much for that warm introduction, and thank you for the invitation to be here today. I've been looking forward to this talk for several months now, so hopefully you all will learn a little bit from this presentation. So I'm going to start sharing my screen, and Happy New Year and Happy Holidays to everyone. Okay, so we are going to be talking about imaging of pediatric epilepsy. I have no disclosures. So some brief objectives for today's talk. We will initially talk about different seizure types, and then review the ILAE, which is the International League Against Epilepsy, classification of focal cortical dysplasia with examples of each of those. And then also review additional causes of epilepsy, including migrational anomalies, genetic mutations, syndromes, and tumors. And that will be it. So just to briefly introduce what is seizure and what is epilepsy, because I think sometimes people get these confused or think that they're interchangeable, which they're not 100% interchangeable. So a seizure, by definition, is a paroxysmal alteration in neurologic function resulting from abnormal excessive neuronal electrical activity. But compare that to epilepsy, which is actually a chronic condition characterized by recurrent seizures, which is unprovoked by an acute systemic or neurologic insult. So again, epilepsy means that it's a chronic condition where they've had recurrent seizures that's unprovoked. And the unprovoked part is important because, as you all know, and some of the things that we will cover is there can be multiple causes of seizures, including in the pediatric setting. If you think about febrile seizures, then that is a provoked instance of a seizure, so that would not be considered epilepsy. So first, to cover developmental malformations. So there's the International League Against Epilepsy. This is the most recent classification of focal cortical dysplasia. I will not read this to you. You all can look this up. And this is really more of a pathologic description, as you can see here, talking about abnormal radial cortical lamination, dysmorphic neurons. But I will say the part that makes this the most different from prior classification systems that you might have heard of is this type 3. So type 3 is basically focal cortical dysplasia associated with something else. And we will review each of these a little bit, but you can see here each category is specific to certain things that it's associated with. So focal cortical dysplasia type 1, and we have in parentheses here isolated. That means that it's not associated with something else. So again, these descriptions are going to be pathologic descriptions, but in regards to imaging, these often are not visible on MRI, but they can be. And some of the things that you can look for or see are segmental or lobar hypoplasia or atrophy, which can be as subtle as seeing reduced volume at the gray-white matter junction, and then any abnormal sulcal gyral pattern. And we'll go through each of these subcategories of type 1. So here is an example of type 1A. So this is a coronal T1 3D image. And I'll give you a second to take a look at this. And then this is the area of focal cortical dysplasia. So if you look at this gyrus that we have circled here with green, you can see that that gray-white matter junction in the cortex itself is kind of blurry if you compare that to the contralateral side. And all of the cases that I'm showing you of focal cortical dysplasia today are pathologically proven. So as you can see, this is going to be very subtle, especially if you don't have a if you don't do a seizure protocol. So very important in a seizure protocol, epilepsy protocol, MRI is going to be doing 3D images, including 3D T1s, such as in this case. And then type 2. So there's type 2A and type 2B. Type 2A is just focal cortical dysplasia with dysmorphic neurons. This is often going to be more difficult to identify on imaging compared to type 2B, which we'll go over. But again, some of the things to look for would be blurring of that gray-white matter junction. So here is an example. Again, this is an axial T1 3D image. Again, very important for identifying these abnormalities. And then this is a corresponding PET MRI. So here, if we look where the arrow is pointing in this left frontal lobe, we have this abnormally deep gyrus and sulcus. We can see on the contralateral side that this goes deeper than the right. And then even that cortex, the gray matter in this gyrus is thickened compared to the cortex in the other regions. And then on the PET MRI, I believe this was a ictal PET MRI. So we're looking for areas of hypermetabolism, and we can see corresponding activity here, FDG activity in that left frontal lobe in that gyrus. Here's another case of focal cortical dysplasia type 2A. I'll give you a second to take a look at this before we point it out. So here with our green circle, you can see that this gyrus and sulcus is maybe just a touch bit deeper than the contralateral side, but really it's that blurring of the gray-white matter junction. So if we look at this coronal 3D T1, we can see that that gray matter just looks a little blurred or smudgier compared to the very distinct gray-white matter junction in the other regions. So again, these can be very subtle on imaging. So type 2B, this is probably what most of you think of when you think about focal cortical dysplasia. In the past, prior to this classification system, it used to be referred to as Taylor or balloon cell focal cortical dysplasia, and the balloon cells from the pathologic description. Again, some of the things we're looking for are similar to the prior systems of having blurring of the gray-white matter junction. Can also have some increased T2 or T2 flare signal in the subcortical white matter. And then the classic thing that you're going to look for is what's called transmantle dysplasia, which I'll show you an example of. But that's basically where there's this T2 hyperintensity in the subcortical white matter that will taper, which means kind of coming down like in a triangular shape from the crown of the gyrus or the bottom of the sulcus that's involved towards the ventricle, and it's usually the frontal horns of the lateral ventricles. But again, some other findings that we can look for are abnormal cortical gyration and sulcation, and this can be as subtle as having just focal enlargement of the overlying subarachnoid space. So here is the first example of type 2B. This is not the classic transmantle dysplasia, but here on this axial T2, we can see expansion of this anterior right frontal lobe. That cortex here even looks a little thickened, and then we have the abnormal T2 hyperintensity in that adjacent subcortical white matter, and then corresponding T1 hypointensity on this coronal 3D T1 here. So this is more of that classic example of transmantle dysplasia. Here on the left, we have a coronal T2 flare, and we can see that abnormal T2 flare hyperintensity in the subcortical white matter, And then with the green arrowhead here, we're pointing towards that tapering of the abnormal signal towards the ipsilateral frontal horn. So this is that, again, transmantle dysplasia. And then the image on the right here, this is kind of an optional sequence, not done everywhere, but this is called T1 magnetization transfer. And this basically gets rid of the background normal T1 signal and makes areas of abnormality stand out. So here we can see that corresponding signal abnormality in that left frontal lobe corresponding to the transmantle dysplasia. Okay, so moving on to the newer category of focal cortical dysplasia type 3, which again is associated with something else. So type 3A is associated with what we call hippocampal or mesiotemporal sclerosis. Type 3B is associated with a tumor. 3C is a vascular malformation, like a arteriovenous malformation. And then type 3D is kind of the wastebasket category of associated with something that's acquired earlier in life, which could be from trauma, ischemia, encephalitis, etc. So here is an example of type 3A. So here, if we look on the coronal T2 with this arrowhead, this is pointing to that left hippocampus, which is asymmetrically smaller compared to the right. We can see here there's increased T2 signal within it. And then on the coronal T2 flare, there's also corresponding increased T2 flare signal. And more subtly, here in the anterior left temporal lobe, we can see a little blurring and increased T2 signal in the white matter of the left temporal lobe compared to the left. See how well defined and T2 hypointense the white matter is here on the left. And then this is a great example of how doing DTI, diffusion tensor imaging, can be helpful in some of these subtle findings. So here we can see the normal green fibers tracking from anterior to posterior on the right in the temporal lobe. And then corresponding to this area of abnormality in the left temporal lobe, we see some blurring of those green fibers, and the green fibers are not as well seen as they are on the right. So just to have a little caveat here, so DTI is not always done in every case in every institution. Of course, there's lots of variation. But at my institution, we currently do DTI when we have ordered or protocoled what we call an MRI epilepsy surgery protocol. So these are patients who have already had a standard epilepsy protocol MR, and they're further evaluating and planning to take them to surgery. So then we will often do DTI so that they have the tractography in case they need it for surgery, especially if there's, say, a tumor, or in this case, if there's something that's causing disruption of the normal fibers. So again, DTI can be helpful, especially for subtle findings. Here is a case of type 3B. This is very subtle, but again, these are pathologically proven cases just to show you how subtle it can be. So here on the coronal T2 on the left, you can see just some subtle T2 hyperintensity in this white matter. This is the left parahippocampal gyrus compared to that T2 hypointense white matter on the right. And then on this zoomed in axial T2 flare, we also see some subtle T2 flare hyperintensity. This actually ended up being a ganglioglioma with focal cortical dysplasia. So that makes this a type 3B. So again, just another great example of how important it is to try to do very high resolution images and take your time looking at these cases, because the findings can be subtle, but are very important, because if we can find these foci for children or even adults who are having medically refractory epilepsy, this can help them, have further evaluation, see neurosurgery, potentially have a resection or treatment. Maybe they need ablation, depending on what it is. And then that can hopefully improve their life. Here's a type 3C. So this is the type that was associated with the vascular malformation. This ended up being an arteriovenous malformation, as we can see on the diagnostic angiogram here on the right. But on the axial T2 here, we can see some cystic changes. We see those T2 hypointense flow voids associated with the AVM. And then in the white matter of that adjacent right frontal lobe, we have some increased T2 signal. And I would not, I would try to think of how to say this, but I would not think negatively of anyone who would just call this cystic encephalomalacia gliosis, because honestly, that's probably what I would have done if I wouldn't have known otherwise. But just try to remember that focal cortical dysplasia can show up as this subtle T2 hyperintensity associated with other findings. So just something to keep in mind. And then lastly, we have that fourth category of type 3D. And this is the one where it can be associated with any other findings that are acquired earlier in life. So this was a neonate who presented with seizures and fevers. And on the axial T2 flare here, we can see some T2 flare hyperintensity. On the coronal T2, there's corresponding T2 hyperintensity. And also there was restricted diffusion in this region. This ended up being HSV encephalitis. The patient was treated and then came back with refractory epilepsy. And here we can see there's now some cystic encephalomalacia in that right anterior temporal lobe. But also, if you look here in the adjacent white matter, there's some T2 flare hyperintensity. So they ended up resecting this, and this was focal cortical dysplasia. So again, many of us would probably just call this some encephalomalacia gliosis, but keep in the back of your mind that it could be focal cortical dysplasia. So moving on from focal cortical dysplasia to some of the other potential findings that we can see in patients with epilepsy, including gray matter heterotopia. So gray matter heterotopia can be sporadic or familial. And like a lot of the things that I'm going to be covering today, they can be associated with other brain anomalies. So as we say in radiology, try not to have satisfaction of search, meaning don't just find the gray matter heterotopia and think that you're done looking, because there can be many other findings that the patient could have. So including KRE2 malformation, which we will not be covering today, cerebellar hypoplasia, PMG, which is Polymankerage, which I will show you some examples of, ectopic posterior pituitary, or agenesis or dysgenesis of the corpus callosum. So gray matter heterotopia can be an isolated finding. The patients could be asymptomatic, or they could have mild clinical symptoms. Typically, they will present with onset of seizures in their first or second decade of life. And again, like we saw previously, they can potentially have focal cortical dysplasia as well. So here we have an example on the left of an axial T2, and then on the right, an axial 3D T1. Quickly scrolling through this would probably say that it's normal, but if you look closely here next to that atrium of the left lateral ventricle, we can see this gray matter signal. So you should never have gray matter signal along the ependymal surface of the ventricles. These often will occur along the lateral ventricles, so make sure you take a close look. And this location in particular posteriorly can be tricky because, as you may recall, if you look on the contralateral side here on the right, there's some similar type signal, and that is the caudate tail. But if you compare that to our gray matter heterotopia here, this actually has an indentation into the lateral ventricle, and that can be a subtle finding that's associated with gray matter heterotopia. Compare that to this more extensive bilateral subependymal gray matter heterotopia. So here you don't even need an arrow to point it out. You can see how I would describe this as like lumpy bumpy. If I was reviewing this with a trainee, like how lumpy bumpy it is along the lateral ventricles. And if we compare that signal to cortex or gray matter in other regions of the brain, it's the same signal. So this is pretty extensive bilateral subependymal gray matter heterotopia. Then we have pollen microage, which can be unilateral or bilateral, can be in different locations, and those locations can determine what type of presentation the patient may have. Of course, we're talking about seizures and epilepsy today, so these patients often will have epilepsy, and they can have other findings as well. So here's an example of pretty extensive bilateral, what we call perisylvian Polymankerage area. So along those sylvian fissures, and this is a common location for Polymankerage area. If you're looking at just the axial 3D T1 here, you might not even be able to tell. So it is important to make sure that you do a 3D T1 so that you can look at the other planes, because that can help. So as you can see here in the middle in the coronal 3D T1, you can see how extensive this Polymankerage area is. So again, using my terminology of lumpy bumpy, this is a very small gyri and very lumpy bumpy along the gyrus and sulci here in the perisylvian region. And then the same findings confirmed on the axial T2 here on the right. It's just more lumpy bumpy than we would expect along those perisylvian regions. Moving on to genetic mutations. So we have hemimegalencephaly. This is actually a hematomatous overgrowth of either all or part of a cerebral hemisphere. They say that about half of these patients have other associated anomalies. So again, another example of not having satisfaction of search. You can have total hemimegalencephaly, which is more rare, but you can have involvement of the ipsilateral cerebellum and brainstem. I have not personally seen this in practice yet. And these patients will often present with macrocephaly at birth. So that will be one hint that it could be hemimegalencephaly is macrocephaly. And of course, these patients can present with seizures, but they can also have hemiplegia and severe developmental delay. So here we have an example. On the left here, we have an axial T2 and then a coronal T2 in the middle. And we can see how abnormal this right cerebral hemisphere is. Sometimes it can be hard to tell in certain situations which side is abnormal if the whole hemisphere is involved. But some of the hints here is that the ipsilateral lateral ventricle is often going to be enlarged. We can see here the image on the right is what we call a T1 IR, inversion recovery, which helps in neonates and young patients when we're looking for myelin. But here we can see that ipsilaterally enlarged lateral ventricle. And then these patients will often have abnormal myelination in the involved cerebral hemisphere, usually hypermyelination, so advanced myelination. And we can also just see how enlarged the right cerebral hemisphere is compared to the left. And the gyri and sulci are very abnormal as well. They're not, as well defined as we can see on the normal contralateral side. Then we have a Cardi syndrome. This is reported to be rare, but I've already seen several cases in my practice. One important thing to note about a Cardi syndrome is it is X-linked. So you're typically only going to see this in females because in males it's fatal. And the classic triad that they're reported to have are infantile spasms. So if you have a patient who is being imaged for infantile spasms and they're female, this is something to consider. Corpus callosal dysgenesis, so that means that it could be just abnormally formed, or they could have agenesis as well. And then something that we're not going to see on imaging, but something that a clinician can see would be chorioretinal lacunae. So they would need to see that with an ophthalmoscope. And as you can see listed here, they can have multiple abnormalities, including within the brain, the eyes, and the spine. So the brain, we already talked about agenesis or dysgenesis of the corpus callosum. They can have gray matter heterotopia, multiple posterior fossa abnormalities, Polymankerage, and another good hint is intracranial cyst. So they'll often have cysts all throughout the brain in different locations. And then in regards to their eyes, to their globes, they can have microphthalmia, meaning a small globe. They can have colobomas, which I've seen most oftenly. And then in the spine, they can also have scoliosis. They say spina bifida, which we know is not a very descriptive term, and hemivertebra, so segmentation anomalies. So my key for you for this is think about this syndrome if you are evaluating a female who's presenting with infantile spasms and they have multiple CNS malformations. So here's an example on the left, and in the center here, we have axial 3D T1s. And just looking at this axial image on the left, a couple of things should stand out to you. So the first thing is these lateral ventricles, instead of meeting in the midline, they're running parallel. And that is always a hint for at least dysgenesis, if not agenesis of the corpus callosum. So we can diagnose that just based on the axial, don't even need the sagittal. Of course, it would be helpful though. And then we can see here in the right frontal lobe with the green arrow, there is abnormal gray matter signal that's going towards that right lateral ventricle. Same thing here on the left. So we have some subependymal gray matter heterotopia, but we also have some Polymankerage in the overlying cortex. And also here, even though this is a T1, we can see a cyst in the right lateral ventricle. That's not a common location for any other type of cyst, like you think about choroid plexus cyst. So this fits with the intracranial cyst indication. And then here on the right, on the axial T2, we also see multiple cysts in the posterior fossa. One here lateral to the left cerebellum, and one here near the cervicomedullary junction, or cerebellomedullary junction, sorry. And then I don't have an arrow on it just because it's subtle here, but you'll have to believe me that here in the center, this left globe, there is a little posterior protrusion where that optic nerve head inserts. And that's what we look for when we look for colobomas, which this patient had. So this patient had many of the findings that can be seen with a Cardi syndrome. So moving on to tumors, of course, a lot of these findings, including the tumors, will often be seen in adults as well. So this is not just a talk about pediatric epilepsy. And one of the tumors is what we often abbreviate as DNET, which is a dysembryoplastic neuroepithelial tumor. This is a WHO grade 1 mass of the cerebral cortex. I will say here I need to update my slides and put these WHO as alphanumeric, or the typical numbers instead of Roman numerals, because that has changed since the 2021 classification. But these patients will often present with partial complex seizures. Pretty much for all of the pediatric or tumors that I'm going to cover in this section are going to be more common in the temporal lobe. So you'll see that on the slides, but they can occur in other lobes. And as we learned at the beginning of the talk, any of these tumors could have associated focal cortical dysplasia with them, which would make it a type 3B. But a DNET often is a well-demarcated, lobulated cortical mass, and usually T2 hyperintense. And pretty much, again, for all of these tumors I'm going to discuss, they may or may not enhance, and that doesn't really change the diagnosis or differential if they enhance. So this patient initially presented here on the left and had seizures and had a non-contrast head CT. And on that CT, we can see this well-demarcated region of low attenuation. And of course, we recommended an MRI because we weren't sure what was going on. And then on the axial T2 in the center here, you can see a very T2 hyperintense mass. And the margins are very lobulated. You might hear people refer to a DNET as like a soap bubbly or bubbly tumor. and that's because of the T2 hyperintensity and the lobulations. And then on the right here, we have a post-contrast T1 with fat saturation. We can see just some mild internal linear enhancement, which again, these may or may not enhance, and that doesn't really change anything. And this is cortically based, and that's why they will usually present with seizures, because it has involvement of the cortex. And again, you can see these initial presentation in adults as well. Then we have what we often abbreviate as a PXA, which is a pleomorphic xanthroastrocytoma. So we're moving up in grades a little bit, but this is still low grade, which is a WHO grade 2. Again, most commonly will present with seizures in either adolescence or young adulthood. Again, most common in the temporal lobe, but can occur in other lobes. And this tends to be a well-circumscribed, again, peripheral or cortical-based mass, but these tend to have more vivid enhancement, and they can have a cyst associated with it, which is more seen with PXA than a DNET. So here we have an example on the left. We have this T2 kind of heterogeneous, but mostly hyperintense mass, and it is cortically based here. And we do see a small cyst along this right lateral margin. And then we also see some T2 hyperintensity in the adjacent white matter, which doesn't really change things if you do or do not see that T2 hyperintensity. Post-contrast in the center, we see very vivid enhancement of that solid component. The cyst itself is not enhancing. And then this patient ended up getting DSC perfusion, so post-contrast perfusion. And we can see here that it's pretty dark, so it did not have hyperperfusion, which fits because it is a lower grade tumor. Then we have ganglioglioma, and these, again, tend to be seen in older children, young adults, often present with seizures if it is cortical based, most common in the temporal lobe. And the interesting thing about gangliogliomas is that their appearance is super variable. So they can be solid, they can be cystic with a mural nodule, they can be mini cyst, but the solid component will typically enhance, but somewhat variably. So these descriptions aren't super helpful. I realize that, but just to point out how variable these can be. And once you've seen several, you kind of know what you're looking for. So here on the left, we have an axial T2 and then coronal T2 in the center. And looking at those, we see this well-defined area that's T2 hyperintense. You might think it's just a cyst, but it's kind of a weird place to have a cyst. And then we also see some increased T2 signal in the adjacent white matter here involving that perihippocampal gyrus. And this patient also had some T2 hyperintensity in the adjacent hippocampus. And then post-contrast, interestingly, the small thing that we thought was a cyst ended up avidly enhancing. So this, again, ended up being a ganglioglioma. And I don't recall 100% if this one had focal cortical dysplasia associated with it. I think it probably did because of that surrounding T2 hyperintensity and the involvement of the hippocampus. But I would say from my experience, the gangliogliomas that I've seen most commonly, for some reason, do have focal cortical dysplasia associated with them. But again, sometimes you're not going to be able to tell that on imaging. You'll see that there's surrounding abnormal signal. And then once they go in and do a resection, if that's what they do, they'll often find the focal cortical dysplasia at that time. So moving on to mesial temporal sclerosis, which some people refer to as hippocampal sclerosis. They say that this is the most common entity in patients undergoing epilepsy surgery. In general, I will say that MTS is something that we see more commonly in adults, but I've seen many cases in children, so it's not just adults. And we saw an example of this earlier when we were looking at the focal cortical dysplasia associated with mesial temporal sclerosis. So here's an example of a patient who presented initially on the left and had a normal MRI. At this time, they had presented with, I think, malignant hypertension in the setting of acute renal failure. And then they came back 4 months later because they had epilepsy. So here, if we look at the left hippocampus on this coronal 3D T1, we can see the left hippocampus is asymmetrically smaller compared to the right. And then on the coronal T2 flare, we can see kind of subtle, but a little increased T2 hyperintensity in that left hippocampus. And then a secondary finding or a hint of mesial temporal sclerosis is asymmetric enlargement of the ipsilateral temporal horn, and that's from the volume loss. If you think about like ex vacuo dilation, this is a great example and hint that it could be mesial temporal sclerosis. So moving on to phacomatoses. So I wanted to talk about tuberous sclerosis. This is an autosomal dominant disorder. I listed here the genes and chromosomes just in case you run across that. But at least in the American radiology boards, I don't expect that they would ask you about chromosomes and genes nowadays, but again, just so you're familiar with it. And the classic clinical triad that is associated with TS or tuberous sclerosis is mental retardation, epilepsy, of course, since we're talking about epilepsy, and then this rash that they get on their nose that you all might have heard about before called adenoma sebaceum. Again, most of these patients, like 90%, they say have seizures, often presenting as infantile spasms. So thinking back, we talked about a Cardi syndrome also is seen presenting with infantile spasms, or these patients could also have myoclonic seizures, and about half of them do have some cognitive impairment. So just so you've heard of this, there are diagnostic criteria from, if you think about the clinical perspective of tuberous sclerosis, we of course are not going to see all of these on imaging, and a lot of these things are not CNS related, but just so you've seen them because might run across them. So we will talk about the CNS findings, but then some other things that they often are evaluated for are cardiac rhabdomyomas. And then in the lungs, they get something called LAM or lymphangioliomyomatosis, and they also can get angiomyolipomas. And then multiple skin findings and multiple renal cyst. Those, I would say, are the most common ones that we run across. So here's an example, and on the axial T2 on the left, we can see some expansion of the bilateral subcortical white matter, some overlying thickening of the cortex, T2 hyperintensity here. So these are what we often refer to as the cortical or subcortical tubers. But actually, if they resect these under pathology, they look no different than focal cortical dysplasia. So these often will be some of the causes of their epilepsy, and they often will have many and have them bilateral. So it can be hard if they're considering trying to do surgery, but sometimes they will do surgery on some of these if they do a workup and say do a PET and other studies as well, and find that one of these tubers or focal cortical dysplasia are the cause, then they might end up resecting that tuber. Then, of course, some of the other findings that we often see with tuberous sclerosis are these subependymal nodules, and these often will calcify. So here on the right, this is a susceptibility weighted image. They can calcify, they don't have to. If they are calcified, if you do a CT, of course, you can see the calcification on CT. And as you can see here in the center image, which is an axial T1 post-contrast, these may or may not enhance. So actually, more recently, we've gotten away from giving these patients contrast because the contrast doesn't necessarily help us find anything abnormal. And of course, you know, now that we know more about gadolinium deposition, and in general, we're just trying to give patients and children less contrast if we don't need to. So these are at that classic location at the foramen of Monroe. So there are different descriptions and definitions of at what point these become what we call SEGAs, which are subependymal giant cell astrocytomas. But by definition, SEGAs must occur at the foramen of Monroe. And really what we're looking for is that there's growth over time. And the concern, because of the location, is that they could cause obstruction of the lateral ventricles and cause hydrocephalus. In the past, we used to just resect these, but now there's medications that we can give, one of which is called everolimus, to not have to do surgery on a lot of these patients. But these are the findings that we're often following when these patients get imaging to make sure that they're not developing a SEGA or hydrocephalus. Then we have SturgeWeber Syndrome, which I actually like the other name of SturgeWeber Syndrome because it's not an eponym and it tells you exactly what the pathophysiology is, which can help you understand. So it's actually also called encephalotrigeminal angiomatosis. It's almost entirely sporadic, and it's really just angiomatosis, of the face. So that is that port wine stain that they get. They also can have angiomas in the choroid of their eye and leptomeninges. These patients, of course, will present with seizures, hemiparesis, hemianopsia, and can have mental retardation. But this last bullet point is the most important point to help you understand. So what happens is they have this peel angioma, so that's the pia overlying the brain, and then that angioma results in impaired venous drainage. That impaired venous drainage results in hypoperfusion of the underlying brain parenchyma, and then that brain parenchyma will atrophy and calcify. That's exactly what we see on imaging. So this patient initially presented here. This is a non-contrast CT here on the left. You might think maybe there was some enhancement and we gave contrast, but of course, always important to look at any of the vessels. If you see the dural venous sinuses or cortical veins, that can be a hint whether or not you gave contrast. But here we see some hyperintensity. So we weren't sure what was going on, recommended an MRI. And on that MRI here, this is an axial T2 flare with fat saturation in the middle. And we can see some T2 flare hyperintensity, some of which you might think is in the cortex, but really this is mainly in the overlying subarachnoid space. So this T2 flare hyperintensity is the peel angioma that we're seeing. And again, remember that's resulting in hypoperfusion of the brain. And then that brain is becoming atrophy and calcified. So here on this, on the right, this is a susceptibility weighted image. I think this was a MIP, maximum intensity projection image. And here we can see dark signal or blooming, which is susceptibility associated with this, or representing the calcification that we're seeing on the CT. So that's really what you need to know about SturgeWeber and the pathophysiology and why we see what we do. So in summary, I think I'm ending right around on time. Hopefully this was helpful for you all. At the beginning, we talked about focal cortical dysplasia. Hopefully I showed how that can be very subtle. So that is why doing a dedicated epilepsy protocol MRI is crucial to try to help find those areas. Of course, not all of them are going to be visible on imaging, but if they are, we can be very helpful in that setting to help the neurologist and neurosurgeons find the cause and potentially treat and help the patient. And then when you're evaluating for cortical tumors in the setting of epilepsy, remember, those can be seen in children and adults, and they may or may not enhance. So that really shouldn't change your differential, but keep some of those common cortical tumors in mind. And that is all that I have for you. You can, of course, find me on Twitter. If you're not already on Twitter, I highly recommend it to get access to other radiology education, and you can always email me as well. I will stop sharing. Thank you.
Thank you so much, Dr. Gadde, for such an excellent talk. This topic is often complex to understand, and thank you for showing us some nice illustrated cases and navigating through it. I see that we have some questions lined up. So Dr. Quikima and he's asking that, do we normally do FMRI in pediatric patients before surgery for those with intractable epilepsy as it's normally done in adults?
Yeah, so I think that will vary from institution to institution, and even from neurosurgeon to neurosurgeon. So at my institution, we do fMRI in children. And of course, it can be tricky because they have to be at the age where they can understand and actually perform. Sometimes language is a difficulty, or if they have other underlying developmental abnormalities like autism, other things that can make it difficult. But we do have specific pediatric neuropsychologists who help us perform those fMRIs, and that can be helpful, and also getting child life involved, which they can be very supportive. But of course, there's research being done in resting state fMRI in kids as well. But more on the clinical side, at least here at Lurie, we do fMRI, especially if they are considering surgery. And, if there's something in particular that they're planning to resect, if there's a tumor nearby, or even if there's an area of focal cortical dysplasia or something that they're planning to ablate, it definitely can be helpful, but just a little tricky. So important to try to do those in a children's hospital with experience.
Okay. Thank you so much. Another question which we have from Dr. Nayabanda is when do we perform FLAIR with FATSAT?
Yeah, so again, that can also be variable. We tend to do our axial T2 flares, and we often will do them FATSATted. I don't know that it necessarily matters 100%. If you can't do FATSAT, I think it still will be helpful. And I will say, actually, now in our pediatric epilepsy protocols, we do what's called a 3D T2 flare. And since it's 3D, that can be helpful for looking at very subtle abnormalities, especially those focal cortical dysplasias. And that's something specific that we've added to our epilepsy protocol.
Yeah, on a similar note, she's also asking if you can go over the epilepsy protocol to kind of help all the attendees to understand what all to include and how to go about it.
Yeah, good question. So as I had alluded to, definitely a 3D T1. So that will depend on, what manufacturer you have, but like a Bravo or an MP Rage, those will be excellent, very crucial for finding some of these abnormalities. And then your standard like axial T2, a coronal T2, but the thing that we do differently about the coronal T2s is we call them oblique, and we oblique them through the hippocampi. And this is even important in the adult setting to try to look for the, hippocampus and look for mesial temporal sclerosis. We do the standard SWI pretty much in all of our protocols now. We don't do, just the gradient echo. We'll do an SWI that can be helpful. We had talked about the T2 flare. We'll do typically an axial T2 flare and then do the 3D T2 flare. We perform ours coronal, and then we get reformats from that. And trying to think, of course, DWI, that's going to be in any protocol for the most part. And then we have a separate surgery protocol, which I had talked about. And that is one where they're planning to do surgery, and they've probably already had the epilepsy protocol. And what we add to the epilepsy surgery protocol is the DTI. And now sometimes we'll do ASL, so arterial spin labeled perfusion imaging. We use that clinically, but that also, people are still doing research on a little bit. Mm-hmm. And that is mainly it.
You also mentioned something about contrast. So in which select cases would you include contrast also?
Yeah, so I think the majority of our epilepsy surgery protocols do have contrast, because at that point we're just trying to do everything, to make sure we're not missing something. But sometimes the neurosurgeons will actually order contrast if they're planning to do some type of surgery, or if they're planning to do what's called depth electrodes or ECOG, like if they're planning on putting electrodes into the brain to actually monitor for seizure activity that's deeper. There they would like contrast because they need to look for cortical veins and know that when they're putting in the electrodes that they're not going to go through a big cortical vein or some other large vessel. But if it's just your standard workup for epilepsy, we typically don't do contrast unless for some reason they, have had prior imaging and they're worried about a tumor or following up a tumor, then we would give contrast.
Okay, thank you so much. That's very helpful. We also have another question from Dr. Ahan. What's the best sequence for diagnosis of focal cortical dysplasia, and can we encounter BRAF mutation in focal cortical dysplasia?
So the best sequence, I don't know that I could say like there's one sequence, but maybe if I could choose two, I would say the 3D T1 and then a 3D flare, because I think that's going to get, your abnormal sulcus and gyrus and like the blurring of the gray-white matter junction. That would help for both. And then if you're looking for transmantle dysplasia, you would be able to see that on the 3D flare. And then maybe if you could do an oblique coronal T2, I would do that as well. And then I honestly don't know about the BRAF mutation in focal cortical dysplasia. I don't know if anyone else knows, but I'm not aware. Something I will definitely look up.
Me too. If somebody's aware, please feel free to add in chat, and then we can also look it up. So we have another question, and it's from Dr. Fabrice Jabara, who's a radiology resident. And he's saying that he likes to know how to differentiate SturgeWeber syndrome and cortical laminar necrosis in infants. And he's wishing you and everyone a happy new year.
Thank you. So SturgeWeber, I don't know a number percentage, but I think the majority of them do have the port wine stain. So that would be helpful to know. And that would obviously be visible to the clinicians. And then, as I had pointed out, if you do the T2 flare, you can see the T2 flare in the overlying subarachnoid space, which you would not see with cortical laminar necrosis. So cortical laminar necrosis, you'll, obviously see abnormal signal in the cortex. You can have the calcification in the cortex and T1 hyperintensity, but you shouldn't really have any abnormality in the overlying subarachnoid space.
Yeah, that's really helpful. We have another questions lined up. So Dr. Quikima is asking again, how often do we find a child with seizures where an MRI seizure protocol is done and the cause cannot be seen? And then how do we proceed, and what's the next step in imaging?
Yeah, good question. I don't know a percentage, but it does happen. So I present, and I would say the majority of our weekly pediatric epilepsy conferences. So I have seen cases where we don't see a finding. And it really depends on what type of seizures they have. Like if they are localized, if they can find a particular area where they're localized to, then they might go on to do the ECOG or the depth electrodes that I was talking about, and try to find a deeper location of where it's coming from. There's, of course, MEG, which is magnetoencephalography, which is not widely available because it's very expensive and complex. But there are several MEGs in the country at large children's hospitals. Those can be helpful. And really just putting all of that together. That's why we do these multidisciplinary conferences, to try, everyone come together to try to figure out if we can find a source. Maybe it's not a structural source that we can see on imaging, but all the other studies can help us find it.
Yeah, sounds good. And then Dr. Ramos is asking us, thin coronal cuts to the hippocampus is default in their institution for seizure protocol. So would you advise against, or is there a better alternative for that?
You said thin cuts through the hippocampus? Mm-hmm. No, I think that's perfect. Yeah. So that's very helpful for looking at the hippocampi for the mesial temporal sclerosis. And that just reminded me. So another thing that we do on our epilepsy surgery protocol is we do what's called an axial 3D space. So, it's a 3D T2, very thin, very high resolution. And sometimes that can help us find abnormalities as well. But again, we really reserve that for the epilepsy surgery protocol. But to answer the question, I think definitely keep doing that through the hippocampi.
Excellent. And somebody's asking what classification is non-Taylor focal cortical dysplasia?
I haven't heard that before.
Yeah.
So the Taylor or the balloon cell is what people used to call the focal cortical dysplasia type 2B now. So I don't know about non-Taylor. I don't know if they're meaning like type 2A or exactly what that means.
I guess so. I guess it must be type 2A then.
Yeah.
And then we have another question which is asking, is T1-MPRAGE done on 1.5T is good enough if it's specific for 8-channel machines for picking up focal cortical dysplasias, particularly type 1?
So it's a little tricky because remember, type 1s can be very subtle. In those cases, I would say you probably should ideally do it on a 3T. We try to do all of our just standard epilepsy protocols, so not the surgery, but the epilepsy protocol we try to do on 3T. We have done them on 1.5 if we've had to for, scheduling purposes. But I would say a type 1 could be tricky. I mean, in general, it's tricky to see. So doing it on a 1.5 is going to be a little tricky as well. But you have what you have access to.
Absolutely. Makes sense. And we have another interesting question from Dr. Accordley, who's asking if the head CT is normal, do we still recommend MRI as always as the next step for someone presenting with epilepsy?
Oh yeah, I would say the majority, at least at my institution, we don't do a ton of CT just because of people's maybe slightly irrational fear of like any radiation. But definitely, I would say if you do a head CT and it's normal and they have epilepsy, especially if it's medically refractory, I would definitely recommend doing an MRI.
Okay, that's great. And then we have lots of comments thanking you for your excellent talk, and they found it really informative and useful. We can just give them a couple more minutes to add any more questions they would like to ask. And while we are waiting, Dr.
Hi, Judith. This was an excellent talk. I just wanted to thank you personally. As you can see in the chat box, there are very good comments of how people really liked your presentation. I'll just read out a few, because we have a few minutes left. Dr. Keenum Zefiteti from Ghana, she's saying very informative talk. Dr. Ukumba Kikiwima is saying excellent talk, Dr. Judith. And then Dr. Jaime Conde-Vargas from Bolivia is saying thank you for your talk. Joshua Baker is saying thanks for the wonderful presentation. Aaron is saying thanks a million. And then Fabrice Nazabara is saying thank you all. I would like to participate in all of your presentations. They're very informative and useful. And Patricia Corley is saying thanks a lot from Ghana. So lots of appreciation, for your wonderful education. More coming in.
More appreciation.
Okay, so Justin Lukiap is saying thank you. Shurinavas Radar is saying thank you, doctor. Enrique Mendro from Mexico is saying excellent lecture, congratulations. Yarmenian Muchtar, thank you from Indonesia. Deborah Hausa, thanks for the talk. Blessing Oni Samson, thanks for the presentation. Dr. Oni Samson from Nigeria. Yeah. So thanks so much for doing this for us. This was excellent. We really appreciate it from the bottom of our hearts. And all our audience, are very grateful for such a wonderful teaching. Thank you so much. And the slides were excellent, the images and the way you explained this topic. That's why I think everybody really loved it. You did a great job. It was such a great education. So thank you so much.
Thank you all so much for having me. This really warms my heart, and it's a great way to start the new year. So thank you. My pleasure.
Thank you. And thanks Aditi for moderating. And thank you everyone from around the world who joined today. And I hope everyone has a wonderful new year and a blessed new year. So take care of yourself, and we'll see you next time. Thank you so much. Take care. Bye-bye.
Take care. Thank you. Bye.